also pharmacists should be on board at this point because I need a lot of, anticipate needing a lot of supplies that are not conventional in the emergency room. Thank you. I think that would be my initial thought process.
Thank you, Dr. Bonnie, for the wide thoughts that you've given us. I think this patient showed us the typical appearance in the emergency department. We get lost. You can easily get lost in the presenting complaint, but he has given us a good expose on how to quickly go through the ABCDE and make sure you've covered grossly what's going to kill the patient immediately. Thank you so much.
And
We'll
Doreen,
go to the
my
next
sincere
station.
apologies. It sounds like our expert, Dr. Naloja, is actually on board. I just quickly recap for her, just be sure that she's caught up on the case, and then proceed. So, Dr. Naloja, it sounds like this was a gentleman, don't remember quickly the age, but who had had 2 weeks of yellowing of the eyes and presented to the emergency room with bleeding from the nose, was vomiting blood, had a fever, was alert at presentation, and hadn't passed urine for 2 days. In terms of the emergency room, they had gotten IV fluids. I think they had taken off samples. They had, if you want to step back, I just want to quickly be sure that I'm not speaking out of tongue on the previous slide. They had drawn samples, and I think the samples had shown a picture consistent with elevated. Sorry, do you want to moderator? Do you want to step back the previous slide? I just want to be sure that I quickly recap for Dr. Doreen. Okay, Dr. Linda. Yeah. Picture had shown a little bit of elevated liver enzymes and declined liver function tests with the hyperkalemia and an elevated creatinine and urea consistent with AKI, and samples for most of the hepatitis panel and HIV were negative. Rift Valley fever PCR was pending. And in the emergency room, they had received IV fluids, antibiotics, imipinem, cilastin, metronidazole. They had gotten TXA, and they had inserted NG tubes, started them on antiemetics and oxygen therapy. I think that was a recap, and I just gone through a quick bit of the ABC and the thought process, and also in terms of consults, anticipating engagement with nephro, as well as blood bank, given the bleeding, as well as AKI. And that's sort of where I'd gone with the case and the proceeding. Thank you.
Thank you, Dr. Bonnie, for the recap. You're welcome back, Dr. Linda. In the interest of time, we will let the presenter go on, and then we shall invite the expert on the next talk. Thank you so much. You're welcome back, Dr. Doreen. Please go ahead.
Okay, thank you so much, Dr. Bonnie, for that extensive overview on what should be done at the emergency department. So moving on, for the hospital course, of course, we admitted this patient to the medical ward. We made sure to get labs like we talked about. We also got imaging and endoscopy, and then we started on conservative management. We managed to put the information, the diagnostic information, in a graphical form that can be easy to understand or can give a clear picture of what was happening with our patient. When you look at the CBC, I want us to take keen notice of the neutrophil count. You can see that the neutrophils were elevated, and this can show us a picture of either an infectious process in the patient that could have come from something that's outside the body, but it can also be a pointer to the chronic liver disease causing portal hypertension that could have caused a bacterial overgrowth in the digestive system, like we are going to talk about later. Then when you look at the hemoglobin, it starts off at a normal level. However, during the course of treatment, the hemoglobin goes down. We were able to curb that because we kept our patient on blood transfusion with platelets, albumin. Yes, and then with the platelets, they were dangerously low, but we managed to put our patients on platelets as well, like we shall see during the hospital course of treatment. So I want us to focus on the liver enzymes. We can see that the ALPs and GGTs were elevated, And when we compare the elevation of ALPs and GGTs to the elevation of ASTs and ALTs, like we already talked about, we have a higher elevation of ASTs and ALTs compared to that of ALPs and GGTs. And this points us to a hepatocellular injury or hepatocellular pathology compared to something that's extrahepatic. So we know that this is most likely an intrahepatic process. And because the AST ALT ratio is greater than 1, it points us even more to something that has been caused by a chronic liver process, chronic liver disease process. Yes, and with this, we concluded that our patient could have a chronic liver disease secondary to alcoholic use. Then when we look at the liver function tests, we can see that the albumin was also below the mean and the prothrombin time was elevated. So the PT-INR was elevated and the albumin and total protein was below the norm. And this shows us that there is hepatocellular injury causing decreased liver function. And from this, we were also able to look at the total bilirubin and the direct bilirubin. We could see that the direct bilirubin was normal. However, the total bilirubin was also normal, but the ALPs were elevated as seen earlier. This shows us that this is most likely an intrahepatic process and most likely a hepatocellular pathology process. Looking at the electrolytes, this is now we are looking at the RFTs. We can see that the sodium was low, was decreased, was lower than the norm. However, the potassium, the urea was elevated, and the serum bicarbonate was at the start when the patient presented to us on admission. Serum bicarbonate was low, however, it increased with time. We're going to see the reason why it did with time during the hospital course. And the serum creatinine was elevated. Having an elevated serum creatinine and an elevated urea shows us that there is an acute kidney injury process. And when we coupled all these findings together, we were able to end up with this patient could have had a chronic liver disease with an AKI. However, when we continued with the investigations, we were also able to do an ultrasound scan for the liver, and we were also able to do an endoscopy, which we shall see later. And with that, we concluded that this patient had a cirrhotic liver with portal hypertension. And when we looked at the endoscopy, we were able to see esophageal varices. This led us to a conclusion that this could have been hepatorenal syndrome causing AKI eventually, which is also very clear in the clinical presentation of the patient. The patient shows us, from the history, we could see that the patient had a 2 weeks history of yellowing of the eyes, and with time, they showed up to the hospital on admission with a 2 days history of anuria, and that clearly shows us a process of hepatorenal syndrome eventually causing AKI. However, all other thoughts are probably I'm open to all other thoughts of the disease process, but when we were in our contact with this patient, this is what we ended up with, and that is how because of the diagnosis we came up with, that is how we ended up treating the patient. So also, I would like us to take keen interest in the LFTs, like we've talked about, the RFTs, like we've talked about, but I also want us to take keen interest in our findings on the ultrasound scan and the endoscopy. And like I've explained, all those things coupled together enabled us to come up with the eventual diagnosis that we did come up with. But like I've said, we are open to all other diagnoses and differentials that could come up. We also thought that because of an elevated neutrophil count, there was a possibility that the disease process happening in the liver was different from the disease process happening with the kidneys. So there is a possibility that the chronic liver disease is a completely different process from what happened with AKI. However, with the ultrasound scan we did and the endoscopy we did, it guided us to the diagnosis that we made. So continuing with the hospital course of treatment, if there are any questions on the results or renal function tests, liver function tests, please shoot. But moving on with the hospital course of treatment, of course, we continued with the backwire, imipenem, cilastatin, and we also continued with metronidazole. We also made sure to put the patient on rifaximin with lactulose, and the reason for this was to curb the hepatic encephalopathy, which we assumed came from the chronic liver disease. Yes, and we also put the patient on Heparmaz, which is L-ornithine with L-aspartate, and that was also to curb the hepatic encephalopathy. And the two, rifaximin and Heparmaz, both curb hepatic encephalopathy by reducing ammonia levels in the body, which we assumed would be a result of the chronic liver disease. Yes, and then we also put the patient on vitamin K because we could see clearly that the platelets of the patient were low and this patient had a coagulopathy. So we put them on vitamin K to curb that. We also kept our patient on IV fluids. We put them on albumin. We kept them on blood transfusion. We added platelets and fresh frozen plasma. And for the hyperkalemia, before we could start the patient on dialysis, we put them on calcium and bicarbonate with salbutamol. And we also continued with IV ulinastatin, which is it's an anti-inflammatory protease inhibitor. And what it does is basically inhibiting enzymes that are responsible for organ injury after inflammation. And this was supposed to help us with retaining or protecting the organs. So it's an organ protective drug. Then we also put our patient on antiemetics, like we had talked about before. This we did at the ED course, but we continued with it. Then we kept them on antipyretics, put them on esomeprazole and tranexamic acid because of the hematemesis and the coagulopathy. Then still for hepatoprotective supplements, we put them on liver-linfort and also kept them on xylibin. We put them on antihypertensives and furosemide because we saw that our patients' BPs were 139/67, which are elevated. And so we kept them on antihypertensives. And with time, we also put our patient on hemodialysis for 3 days. And then we asked them to come back 3 times a week for the next 2 weeks. Yes. So we had already talked about the virology where we said we had the Rift Valley fever, PCR positive. And we've talked about the ultrasound scan where we concluded from the results of the ultrasound scan that we had a cirrhotic liver with portal hypertension. And with endoscopy, we were also able to conclude that our patient had esophageal varices. Yes, so in case of any question or anything that you haven't understood, please shoot. But I would also like to invite the expert to give us additional information on what should have been done and what was left out. Thank you.
There were some
Doctor?
questions from the audience, moderator.
Oh, I noticed Dr. Deogratius had answered most of them. He has kept the chat active.
Yeah,
So-
he stepped off about 8 minutes ago. He had to attend to a case, so the last ones that came through, he didn't respond to.
I could answer those from what I'm seeing. Was there ascites? No, because when we did our secondary survey, we stated that the abdomen was soft. It was not distended. However, we had epigastric and right upper quadrant tenderness. There were no signs of peritonism. Then was the patient tested on any of the hepatitis? Yes. From the results, we were not able to include those, but we shall probably add them to the slides. Yes, we tested for all hepatitis. Hep A, Hep B, and the patient was negative for all those. The only viral disease the patient was positive for was Rift Valley fever. Then wasn't this more of a fulminant hepatic failure? Well, that could be the case, but while we thought of all those things at emergency department, we were also able to look at what we got from the diagnostic results, like the LFTs, RFTs, ultrasound scan, and the endoscopy. That is why we concluded with what we had. Yes. But I am sure the expert is going to add more on that. Then in hepatorenal syndrome, taliprecin is always a wonder drug in managing ascites. Did you consider it? Okay, I can't answer that because I am not sure what taliprecin is. So I will leave it to the expert or my mentor to answer that. Is it possible to give us a pathophysiological process capturing the Rift Valley fever infection as a factor in the disease process, or can we consider it as an incidental finding? At the time of diagnosis and treatment of the patient, we considered it as an incidental finding, but we also didn't really go with it because we used the PCR test, and we all know that PCR is sensitive, however, it's not a specific test. Then did you particularly go in for? No, we did not, because we used the PCR test, which is sensitive and not specific, so we could not pin it to Rift Valley fever. Yes.
Dr. Doreen, I think we'll answer the other questions at the end of the conversation. So let's give the expert time to give us an opinion at this point. We're going to answer some of the questions at the end of the session, or in between. We shall get some time in between. Dr. Linda, you're welcome at this point. Thank you.
Yes, good evening, everyone. This is Dr. Linda speaking. Thank you to our presenter for sharing with us your patient and how you went through the management for the patient. Sorry about the snags for the internet on my side and the connectivity. I'll begin by first slightly taking us a little bit back to when the patient had initially first presented to us in our department. Either this could be answered by the presenter or just anyone volunteer from our audience. Thoughts or concerns when you hear about this patient's history, just by the little history you've gotten and also just a little information from the ample history. Is there any concern for anything major? I know most of the things have been hinted on, but remember, in our approach, we are looking at the ABCD. But before we go to that ABCD, what initial thought comes to you before you get into the vicinity of this patient? Anyone volunteer from the audience or the presenter can highlight on that? Because I've had her mentioning. Yes?
I think for this particular patient, you'd be cautious with body fluids because they presented with hematemesis, epistaxis. So you'd be cautious with make sure you wear gloves and make sure you have all your protective gear on.
Yes, that's very important. So as you approach this patient, already you're having that initial, it's more like your initial working diagnosis or what could be some of the public health concerns or a life-threatening concern as you come into this patient. So as you're thinking through the possible parameters that could be wrong with this patient, I heard someone was asking, how sure were we that this patient wasn't having a picture of a fulminant hepatic failure? And this will be elaborated in the more information you'll be able to tease out from the sample history. And also, when you do your ABCD approach, what was outstanding for this gentleman, I see that throughout the time they're with you and prior to presentation, their level of consciousness or their mental status stayed what you would call around 15 out of 15. So this also gives us a picture on what could be happening. And here you're wondering, could this patient be having a hepatic encephalopathy? Because as you're thinking through with just the initial approach, the history and the examination, you're trying to think through what could be the possible life-threatening causes that could make this patient present to you the way they are presenting. And given his age, if there is any risk of the travel history, given the location of where we are currently, and if there is any major incident or any epidemic happening in your environment, that's very important to note. Your life-threatening causes that would be worrisome for you would be if the patient had fulminant hepatic failure, someone had hinted out, or if they're overtly having a massive hemolysis ongoing, or if they're having any intoxication. It could be a drug overdose of something or any other accidental poisonings, which is normally common in people who have been traveling and they have picked up something. So when you go ahead in your department to investigate, there are things that you can do bedside to help you know that this is a possible thing I'm dealing with. Or as you're assessing, you're also trying to see that either this patient has complications from what could be the possible cause of their presentation to you. And as you're investigating them or examining them, you're able to pick out some of these things. And one of the outstanding things was the history of not passing urine for 2 days. And when you're given this information, you begin to worry about the electrolytes. In this patient's examination in the ABC, I see that all their vitals were grossly within the normal parameters, I think, except for the temperature being slightly high. At this point, we don't know if a urine catheter was put in, but there are things you can do bedside, because I know in the setting where we are, getting some of the important labs that would come in to help you zero down to a particular thing or to manage something might take some time. So important to note is that there are some particular bedside investigations that can be done in addition to the labs you might have taken off to determine what you can do as you are at the bedside of the patient. Among the things you did here for this patient, I think I might have missed to see what the glucose, the random blood glucose measurement was, but should also have helped us to know. And then another thing we might have done bedside is to see, because it told us that this patient had been having Bellina stools, so getting a coagulopathy profile for this patient. If your CBC was able to come back immediately, you're also able to determine some very important parameters. Could this be an infective cause? And as we are thinking, since we have the bleeding, the yellowing, you're worried about your HB levels. Is this, if it was to be a massive hemolysis ongoing, you'd be able to interpret that. And then also importantly, when you're thinking of your acute kidney injury, there are other parameters that will point towards a life-threatening event. For example, you talked about the hyperkalemia. So in case your labs might take some time to come back, when you're able to have an ECG machine bedside, you're able to do this, and there are particular things you'll see that will indicate for you to immediately intervene at this point in time if there are obvious features of a hyperkalemia, and also as you wait on your labs to come back. And as the presenter mentioned towards the end, she managed the hyperkalemia bedside for the patient. The other thing to look out for, possible signs of an infection. You told us that this might have been a chronic picture. So sometimes thinking through, is it an acute or chronic? In your examination, you gave us a thorough abdominal exam because you're trying to determine also other possible causes. And here you're worried about an infective cause that might be also pointing you towards a fulminant picture so that you're able to manage this patient. Important to note that this patient was managed with your team. We are not able to determine for how long they are with you, and also at what point you engage the other consultants. And normally what is important at this point, because you've already assessed the critical nature of the patient you're dealing with. So as you're stabilizing them, resuscitating them, and running your labs, at this point, being in consultation with the other consultant, as the other workup guides, might also help you to continue having a continuum of care to know where the patient will go or what specialty they will need immediately. Bedside, the other thing you can use is your ultrasound. Your ultrasound will help you determine any other important things. The good thing with this patient, they were not producing urine, but they didn't have obvious signs of shock. And in case you want to give them a fluid challenge, you're able to use your ultrasound to assess if there is any other fluid overload in the critical areas. Here, your concern is about the lungs because you want to give them fluids and see if you want to push them into a fluid overload. You want to challenge them and see how much urine they'll be able to produce for you. And also at the same time, you're able to look in the peritoneal cavity. You're also able to assess if for this particular age, what other things could be making him not to produce urine. Could it be that there are obstructive features? Because as you're having your list of differentials, you're thinking of possible causes, either a direct cause with a primary kidney insult, or you're having the primary insult from the liver and it's now progressing to affect other organs. So having your ultrasound to look at the kidneys, to look at the urinary bladder, if it's really empty, or if there are any signs of a hydronephrosis. However, note that this ultrasound skill is subject to the operator, so it is user dependent, and then the skill that the person has and the confidence in interpreting what they are seeing. I don't know if I've responded to one of the questions that was being asked on the chat. If I've missed it out, it can be highlighted to me later on. Thank you.
There are two questions in the
Dr.
chat.
Linda?
Sorry.
Yes.
Thank you, Dr. Linda, for the response. Dr. Boni, please.
No,
Go
I
ahead.
just flagging two questions from the chat. There was one about a possibility of drug-induced liver injury. There was also another one about viral hemorrhagic fever, which I think you've responded to.
Okay, thank you. Thank you, Dr. Linda. Thank you, Dr. Boni. At this point, we want to go back to our presenter. Dr. Doreen, please come forth and continue with this interesting case.
Thank you, Dr. Anna. Thank you, Dr. Linda. Thank you, Dr. Boni. So moving on with the case. Could you please help move the slides? Thank you so much. So the key issues that we have to take note of in this patient are that we have a hepatitis, and we can see that from the elevated liver enzymes. We have a probable Rift Valley fever, and we are sure that we have a liver failure because we have done the coagulopathy tests. We have an elevated PTINR, and that clearly shows us that we have a coagulopathy. We have low albumin, so we know that even our liver function tests are showing us that we have a liver insult. Then we are sure that we have a subclinical chronic cirrhosis because we have seen it from the ultrasound scan, and we can also see it from the endoscopy that was done. Then we are sure that our patient has an acute renal failure from the anuria, but also from the test, we could see that we have a hyperkalemia, we have uremia, and we also have elevated creatinine. We have a hyperbilirubinemia, which can be seen in the clinical picture with jaundice, and we have upper GI bleeding that we can see on the endoscopy. And I think this is the point where I am supposed to invite the audience to share with us their differentials, which they have done in the chat, and Dr. Linda has gone through each and every one of them. I think there's someone that has an issue with hearing. Is there a problem with? Can everyone get me?
I can hear you. The issue might be with their sound system.
Okay, thank you. Yes, so I think Dr. Linda should come in now. However, she had just taken us through it. But if there is anything that she would love to add on the different differentials that we came up with, yes, I would love to invite Dr. Linda to do that.
Yes, thank you. So putting together so far what you've seen with your patient examination, their progress and response to your interventions, and then some of your labs, as I mentioned, you're having particular differentials going through, and you know how you're going to be able to intervene or to manage, or who else you're going to consult. So among your lists, I see the infectious causes. That's very important to note. And we know these ones will mainly come in to cause your hepatic picture. And as you know, as you're interpreting your bilirubin levels and in conjunction with the other parameters from the liver function tests and the other supporting labs, you're trying to understand where the insult might be. Is it pre-hepatic, hepatic, or post-hepatic? So having infectious causes here is important for us to know. Poisoning, I think I had hinted about that. It can also fall under the intoxications. Common in our setting, we have the warfarin, as you've mentioned. We can also have the acetaminophen. So remember that when you're in the ED and you receive a patient, sometimes you have the liberty of gaining so much information, though sometimes you don't have any particular history. So once you have this at the back of your mind, it's also important for you to do a toxic screen for the patient, because once you don't identify that it's a possible intoxication, I don't give the right antidote, chances are high that you're going to have a worse outcome. Autoimmune hepatitis or autoimmune causes, that's quite common. For people who already have the ascites and then getting a spontaneous bacterial peritonitis is also possible. Then we see our chronic alcoholics coming in with the alcoholic liver disease. That's also likely, given our setting and the socioeconomic status of where we are. Carcinoma, that is likely. So for this presentation, this carcinoma could either be within the liver parenchyma itself or even in the surrounding tissues, blocking the bile duct or originating from the pancreas, or even metastasis to the liver. Sometimes it's hard to know which one came before. Is it the liver that caused the insult to the kidney, or was it the kidney that ended up throwing someone in the state that this patient was in? So having a glomerulonephritis is also possible. However, important to note that sometimes it could be because it could be a complication of the primary problem that is making the patient now have other features coming in. Or sometimes if we fail to identify these things in time and give particular medications, we could also iatrogenically be the ones causing some of these issues. The other thing that we could add for this particular patient, I think it might lie in the line of obstruction, anything happening with the bile duct or having gallstones in there, inflammation or anything that will cause obstruction can also give you this kind of picture. Is there any question I've missed from the chat?
I think
None,
the
Dr.
questions were
Linda.
checked also.
Okay.
Okay. Dr. Linda, are you still adding more points or you're done?
Maybe just on the any extra differentials would be around the possible causes of your acute kidney injury in this patient. So determining if it is within the renal parenchyma itself, as you're hinting here for the glomerulonephritis, or if it is a pre-renal, where anything that is happening within the patient, giving them any fluid depletion or fluid loss, or sometimes even drugs that are causing renal toxicity could also give you this kind of picture. So if we're able to hint or tease out anything from the patient's history, it will be important for us to use that to support for the different differential diagnoses.
Okay, thank you so much, Dr. Linda. Over to you, Doreen.
Okay, thank you so much, Dr. Linda. So with our patient, we concluded with hepatorenal syndrome, and I'm going to take you through the course why we concluded with that. Our patient presented with a 2 days history of anuria. They also presented with a 2 weeks history of yellowing of the eyes, with hematemesis, epistaxis, with right upper quadrant tenderness and epigastric tenderness. So from the clinical picture, we can see that our patient showed up with the differentials that we come up with here. We know that we either have a liver process, but we also most probably have a kidney process happening. So we concluded with hepatorenal syndrome because from the results that we got, we saw that the ASTs were elevated and the ALTs were elevated, but the ASTs were way more elevated than the ALTs, giving us a ratio that's greater than 1, and that pointed us to a chronic process of liver failure. So we concluded this patient could have had chronic liver disease. However, when we also did the RFTs, we had a hyperkalemia, and we also had we had hyperuremia, and we also had elevated serum creatinine. And this pointed us to a kidney injury, and most likely an acute kidney injury. Why we actually completely concluded this is an acute kidney injury is because over the course of treatment, we had the patient for about 19 days during the hospital course of treatment, and during that time, we were actually able to take the kidneys back to their normal function with normal liver enzymes. So we concluded when we did the ultrasound scan, we were able to see a cirrhotic liver with portal hypertension. And so all these things coupled together, we could tell that first of all, from the history of our patient, we knew that they were an alcoholic with a KED score of 2/4. So we concluded that that this patient had an alcoholic process causing chronic liver disease that eventually resulted into a portal hypertension that led to upper GI bleeding with esophageal varices, and eventually, because of the portal hypertension, because of splanchnic dilatation and hepatic vessel constriction, this triggered, because of a splanchnic dilatation, that there was a hypotension in the body, which triggered the RAS system that was supposed to compensate for the hypotension. And with that, there was also renal arterial vasoconstriction. And that eventually even caused more injury to the kidneys, because that means that there was very little blood supply to the kidneys, causing an AKI. And so we concluded that we have a hepatorenal syndrome with AKI. And with that conclusion, we treated our patient as I took you through it with a hospital course. And I think I have given an overview of what a hepatorenal syndrome looks like. We have 2 minutes to the end of time. So some of the etiologies are we could have kidney failure due to circulatory changes, like I've already explained. And in this particular case, we did not think there was particular direct kidney etiology. Also, during the ED course, I think something we forgot to add to the slides, we did catheterization just to make sure that we do not have an obstructive cause. But also with ultrasound scan, we had to make sure that there was no obstructive cause. And we actually concluded that our patient was anuric because of a primary kidney injury or kidney insult. So we could have type 1, which can be because of acute decline, but we could also have type 2, which could be because of gradual decline in chronic kidney disease. And liver failure can also trigger a cytokine release, and vasodilation, like I've already explained to you. Because of this, we shall eventually have the RAS coming in, we have angiotensin to release, and then we eventually have renal vasoconstriction, which actually just exacerbates the renal injury. For the management, we put our patient, I put you through the things we put our patient on in the hospital course. However, you want to avoid nephrotoxic agents. You want to ensure sufficient volume. If there is volume depletion, that's the reason why we put our patient on IV fluids, and we continued with that, kept them on albumin. Then you want to correct any obvious triggers. Another possibility is that because of the portal hypertension, there's bacterial replication in the digestive system that can actually eventually lead to a septic process that can be the cause of AKI. So you want to make sure that that is not what you're dealing with. Then you put your patient on dialysis like we did with our patient. And in some cases, you might have to take the surgical route of transjugular intrahepatic portosystemic shunt in case you have a fulminant portal hypertension. Then you want to also manage the cause. In some cases, you can do liver transplant, or you can optimize liver function by putting your patient on rivaximine, lactulose, Levofort, all those things that we've talked about before. Yes, and with that, I think if there is any question, any addition or anything that you would like to add to the case, or you feel has not been clear, please, this is the time to come forward. Thank you. Thank you so much for listening, and thank you so much for tuning in.
Thank you, Dr. Doreen, for giving us an elaborate expose of your case. Our time is fast spent, but I'll ask Dr. Linda in 1 minute to give us a take-home or a PAL for this case that we can take home for emergency care. Thank you.
Yes, thank you very much. So to summarize it all, it's from our approach and having a wide idea of what could be wrong or what could be happening in this patient. So you having clear knowledge on what could be the possible life-threatening causes, knowing the possible complications that the patient will come with to the ED, then you'll strategize in your approach, keeping safe, keeping the patient alive. So using your ABCD approach to intervene for the life-threatening complications they will have. So resuscitate your patient, keep them stabilized, get the appropriate investigations. Earlier on, begin consulting with the appropriate consultant and know which patient will be for either an admission right away or the kind of patient that will need to be followed up in the ED. The kind of patient that has the overt jaundice, any signs of hepatic encephalopathy, pains, other systemic symptoms, deranged parameters as per your investigation, that's the kind of patient you need to admit and have the appropriate consultant who will either determine whether it's going to be conservative with IMED or surgical, that will also need to be followed up in either the ICU or the HDU. Plus, as you're intervening, remember to reassess where patients don't respond appropriately, like for example, of retractable hyperkalemia, in the view of the possible cause that could be amenable to dialysis, then you'd also want to engage that management earlier on for the appropriate outcome. And as our presenter has summarized it, their final working diagnosis, this shows you that when you're managing the patient, identify the possible risks that are going to make your patient get the hepatorenal syndrome, prioritize them, optimize them, then you'll be able to reduce the risk, because as you see, fatality is common with hepatorenal syndrome, and one of the things that will give you a good outcome is if you have a liver transplant, which won't be readily available in our setting. So optimizing your patient, once you begin to get the liver function coming back to normal, then chances are high that you're also going to recover from your hepatorenal syndrome. Thank you.
Thank you so much, Dr. Linda. We want to acknowledge the people that have been behind the scenes while preparing this session. Dr. Dale Gracious, who has been our mentor for the case. Thank you so much. The Secretariat, we have Dr. Jimmy, we have Dr. Tunamasko, Dr. Boni, Dr. Olinga, Mr. Okumu, thank you so much for the great work that you have done. And to everyone that has tuned in today's session, we are very grateful to have you today. Just a reminder, these sessions happen once every month. If you have an interesting case, please reach out to Dr. Atiera Jimmy and let's share the case, let's learn together. And also remind your colleagues to tune in once these links are shared. It's a platform to learn together and grow in emergency care. Once again, thank you so much for tuning in, and till next time, bye.